continue on to Joe Eisenberg, who is a professor in epidemiology and an expert in infectious disease epi and modeling, particularly focused on waterborne and vector-borne diseases, but also a wide range of other things. And he's going to be talking today about some integrating, thinking about trade-offs between quarantine length and compliance when we're thinking about COVID control and interventions. So maybe with that, I'll switch it over.
Thank you. Thank you for the invitation to talk today. Like many of us, with coming of COVID, we've shifted our work from what we normally do into COVID. I am an infectious disease epidemiologist, largely focusing on enteric pathogens and waterborne pathogens. And so this is new to be looking at a respiratory pathogen like COVID. But I think there's a lot of cross-cutting issues and questions that really cross many different infectious disease systems. And one of these is this question about trade-off between our decision on what to intervene on and decisions on how to intervene, and adherence or compliance to that. And there's many interventions in my world with respect to water and water quality. The efficacy of a water filter used in a household is often defined by microbiologists and by the microbiological characteristics of that filter. Often little attention paid to uptake and usability and such and compliance. And that trade-off is incredibly important in trying to optimize how effective an intervention is. And so quarantine length is another excellent example of this with respect to this trade-off. So I also like to say that this is work that was done in collaboration with others, Michael Hayashi, who's soon to become a faculty member in our department, as well as two amazing, excellent students, Kayu Zhao and Sophia Simon, participated in this specific project. Lots of students have participated in a lot of this kind of work, and it's been great to see that kind of synergy happening in this, in the work addressing many of these COVID challenges. So, to start off, with respect to quarantine duration, much of the duration and the guidance has been based on both the maximum observed incubation period as well as assuming perfect compliance. And we've all heard, in the recommendation of a 14-day quarantine, which has been began in the early parts of this pandemic. And then later on, there start to be questions about whether or not we should shift to be 10 or 7. CDC is still sticking with this 14-day quarantine, acknowledging that local and health departments may be opting for shorter quarantines. But the result is a somewhat fuzzy sense of what guidance there should be with respect to quarantine. And I think the issue here is there's really few rigorous evaluations of the effectiveness of quarantine duration. And that really prompted us to think about this question in a more quantitative way. So let's just start with thinking about the incubation period. We've heard a lot about the fact that incubation period can range from 2 to 14 days, but incubation period follows a distribution. It's highly variable. If we look at the incubation period for COVID-19, excuse me, we see that by day 7, over 73% of the people present with symptoms that they're going to be presenting. By day 10, it goes to 91%, and by day 14, 97.8%. So even by just looking at this distribution of incubation periods, we realize that quarantine benefit may be subject to this concept of diminishing returns, that as we ask for a longer quarantine time, the incremental benefits are going to be less and less. And as we know, the costs of this increased quarantine time as I'll talk about a little later, increases. So it's important to think about the trade-offs between this quarantine duration and compliance. And as we know, characterizing compliance is very complex, highly dynamic. It's affected by many social cultural factors as well as environmental factors. There's going to be financial and psychological burdens that may motivate why somebody doesn't comply or is not going to be adherent to a given intervention and quarantine duration. And a lot of this complexity is illustrated in this review. There's few data that really are trying to quantify this question of compliance. Here we see a review that takes single point estimates of adherence compiled across multiple outbreaks. And the result of this review paper is that there's mixed results and very kind of paradoxical findings in this, precisely because of the fact that compliance is context dependent, and that by comparing compliance data across outbreaks, it's going to be very complicated to really tease apart what those determinants of compliance are across these different settings. So the second piece is that measuring compliance is difficult. As we see in a few of the studies that we've looked at, for example, this mumps study, where in the midst of this one single outbreak, the recommended compliance and the duration of compliance, the recommended quarantine length varied throughout the outbreak. Right? It started at 4, went to 9, back to 4. And so this compliance information is confounded by these changing quarantine length recommendations during that outbreak. We see in a second study, there we go, that we looked at and found that quantifies compliance. There was a situation where in this influenza A study, there was a conflation between, they conflated quarantine and isolation. And as we know, once you have symptoms, your compliance to isolation is likely to be much longer than quarantine, your compliance to quarantine, where you're quarantined without any symptoms. So again, lots of mixed information and difficult interpretations occurring in this particular study. So in the midst of this, I think a lot of these data provide us with some insight in the direction that we might want to go with respect to modeling, but also acknowledging the difficulty of actually measuring compliance and the complexity of what goes into this dynamic process. So with that, we developed a model, which on the surface, if we look at the disease progression part of the model, which is the if we look vertically in the colors, we see we have what we call an SEIR model. We keep track of the number of susceptibles, the number of exposed or latently affected who are not infectious yet. We then account for asymptomatic and or pre-symptomatic, followed by symptomatic, those that are infectious and then those recover. So that's occurring in this model as we go from the top to the bottom. As the model then also keeps track of the quarantine progression, as we see at the bottom here, so that as we move from left to right, individuals that are quarantined move through this quarantine process. So the idea here is that contact tracing places non-symptomatic people into quarantine. Those people are either have been actually exposed and are going to be moved through the disease process, or they're going to remain susceptible. And then on the right here accounts for the people that exit the quarantine process, either because they completed it or prematurely because of non-compliance. So in all this, the fundamental assumption here is that anybody not quarantined, are individuals that contribute to the disease transmission process, and anybody that is quarantined does not. So then the question is, how do we model compliance, which again, as we talked about, is a complex process. So we started with a simple model where people asked to quarantine. The assumption here is people asked to quarantine for longer will leave at a higher rate. And this graph shows you on the x-axis the progress through the quarantine period measured in days, and on the y-axis the rate of leaving quarantine early. So the steeper the slope, the more non-compliance there is, and the shallower the slope, the less compliance there is. And then we see in this model, we're assuming that if you're asked to quarantine for 10 or 7 days, your rate of non-compliance is less than if you're asked to quarantine for 14 days. So if we look here more specifically, on day 8 of a 14-day quarantine, each person has 60% chance of leaving, whereas on day 8 of a 10-day quarantine, each person has a 47% chance of leaving. So this is one model of compliance that we looked at. There are also other models we've also looked at as more of a kind of a sensitivity analysis, where here the assumption is there's uniform complete compliance early on, that no matter what you're asking somebody to quarantine, no matter what duration, people will by and large comply early on, and then there'll be this increasing non-compliance slope that's variable depending on the recommended quarantine time. Similarly, we might think that there's uniform non-compliance. So there is some non-compliance happening early on, but it's pretty much uniform regardless of how much time you're asking somebody to quarantine. But just before your quarantine ends is the time that people will tend to leave quarantine early. So these are all different kinds of models that we can explore with respect to quarantine. So here's some results that come when we simulate these different kinds of models. Here we're seeing on the x-axis increasing rates of leaving quarantine or non-compliance. The right is the attack rate, or can think of that as the cumulative incidence. And so we see the first concept that we want to drive home, and that is the concept of diminishing returns of longer quarantine time. That as we see that if we increase the quarantine time, the incremental benefit of the increased in quarantine recommendation is diminishing. So we see very little difference between a 10 and a 14-day quarantine. Under this situation where actually compliance is quite high. So this, in the left side of the graph, would show us high compliance, very little difference with respect to cumulative incidence, with respect between a 10 and a 14-day compliance. As we increase compliance, moving to the right, we see that there is diminishing returns again with respect to the benefits of a 10 and a 14, even compared to a 7-day quarantine period. So again, this actually model is one in which the different recommended quarantine times have the same rate of non-compliance. So if we remember in that last graph, it's actually the slope of non-compliance as you increase the amount of time you're in quarantine is the same. So we see this diminishing return phenomena as we increase the amount of our recommendation for quarantine time. So now if we look at another model in which we now assume that as you increase, the request for or the guideline for increased quarantine time will actually increase your non-compliance, we see that compliance behavior can actually amplify the benefits of this short-term quarantine period. So now, as non-compliance increases, we see that the shorter quarantine times are actually more beneficial and more effective than a longer quarantine time. And so again, this is where longer recommended quarantine times have increased rates of non-compliance. So we can see this issue and of trade-off that we need to consider in the context of developing a recommended quarantine time. So in closing, just the idea here is optimal quarantine plans, or designing an optimal quarantine duration, really needs to consider both the full distribution of the incubation period, as well as potential compliance issues. So when considering the full incubation period and the full distribution of the incubation period, the one take-home message is we see diminishing returns, and these diminishing returns become very apparent as we move to, especially when we move to 10 to 14 days. So we see very little benefit of actually a 14-day quarantine period in almost all assumptions of different ways in which to model compliance. And even when we think about perfect compliance, when we take into consideration this full incubation period. So furthermore, when we think about sort of the economic and social costs and burdens of quarantine and the issues that come into lacking of adherence, it further strengthens this argument for shorter quarantine times as an optimizing effectiveness with regards to the intervention. And I just want to close to emphasize this fact that when mitigation strategies are determined solely by clinical or biological features and ignore the social structure and the behavioral structures, we get misleading kind of sense of what the optimal interventions are. And I think that I've seen this over and over again with COVID. I've seen this over and over again in thinking about waterborne pathogens, that our focus is often on these biological clinical features and not on understanding the social structure behind this. And so when we want to intervene and want to come up with interventions that affect populations, that affect communities, we really have to understand the context in which we are placing these interventions, placing these recommendations, because ultimately the community that's involved needs to buy into these recommendations, needs to have ownership, and needs to be engaged in order to really have an optimal solution with respect to interventions. So that's all I had, and with this, I'll open it up for questions.
Great, thank you, Joe. That's such a great point about community engagement, and something that I think modelers and all of us could probably benefit from thinking about more.